So, guys, we might get started. Anna apologizes. She's on leave this week. So, Anna will be back running the tutorial in 2 weeks. This week, we are going to chat about echo findings in heart pathology. Um, we can do this. My idea is I want to kind of do this with you guys, showing you some real echoes of our cine loops that we've taken, and just kind of chat about them and get a bit of an overview. But I'm gonna start with kind of the I don't want to say basic views because they're not, but the sort of first views that I think are good to master. But if anyone is doing echoes in practice and really wants to jump in on a specific topic or burning questions, then please just mention throughout. On that note, is anyone that's present doing echoes in clinic that really wants to has a burning question, or just kind of happy to go with the flow?
Yeah, go with it, Helen.
Okay, great.
Go with the flow.
I'm I'm going to share my screen.
Do what you do well.
So if anyone's doing echoes already, these views will look quite will hopefully look familiar. Um, and if not, these principles can absolutely be applied to like a cardiac POCUS exam, everything that I'm going to talk about. So even if you don't have an echo probe in clinic, even if you don't have an echo mat in clinic, these principles can absolutely apply. But just to standardize the views I'm going to refer to and show you guys are standardized echocardiogram views, not kind of POCUS views, because obviously contextualized to your patient, you might be performing a cardiac POCUS with the patient in sternal or however, and then knowing your anatomy really well to know what view you're looking for is important. These views I'm going to show you are all kind of the standard echo views, which if you're doing an emergency patient, you might have a patient that's too compromised to lay in lateral for these views. I'm going to show all the same views so that we could all just get sort of subjectively used to looking at an echo image and then making some kind of subjective assessments on it. 'Cause I think that's helpful. So this first view that we're going to chat about is your patient is laying in right lateral with their heart over the cutout of the echo mat, and you're scanning from underneath. So we're doing a right parasternal long axis view. If you imagine where the heart lies in the chest on a thoracic radiograph, you're lining the probe in long axis up with the heart so that you can see both atria and ventricles in long axis. So this is our right parasternal long axis view. An important point if you're not doing echoes routinely is the image is flipped when we do echoes for reasons I don't know. So in a hopefully you can all see my screen, hey?
Yep.
Amazing. Okay. So when you're doing an abdominal ultrasound, your E or your little marker will always be either side, but in an echo, your image is flipped. Now, why that's important is if you don't have a cardiac probe in practice, you can absolutely practice cardiac views with an abdo probe, but you either need to tell the machine to flip the image, so make sure the E is the other side, or instead of your light of an abdominal probe or your notch facing cranially, you're just going to rotate it around so it's facing caudally, so your image is flipped. That means that we're used to seeing the caudal aspect of the image on the right hand side of the screen. You know, if this was an abdomen, this side, the right, would be caudally, and this side on the left would be going cranially.
See what she's saying.
But in echo, this right hand side is cranial. These are our atria on the right hand side of the screen, and these are our ventricles on the left hand side of the screen. So if you have a cardiac probe set up, your notch or your light in this view, in long axis alongside the heart on the right side of the chest, the light of the probe will be facing towards the patient's head. But if you're using an abdominal probe to practice these views in practice, just rotate your probe 180 degrees, the opposite way to you're used to using it, with the light now facing caudally. And that's important because even if you're using an abdo probe, you want to get these views because these are the standardized views so that when you Google, why on earth is my right atria so massive, the views that pop up on Google are the same as the views that you're collecting. Does that make sense? Great.
Yeah. But Helen, you can usually flip that on the machine though, can't you?
Can
Like,
absolutely flip it on the machine as well. Yeah. So it's just an important point if you're doing that, because if you get the atria on the other side, you then go to reference resources to try and have a look. It's really overwhelming what's going
um,
on.
yeah,
So
this is-
on that um on that breath of me just saying atria on the right, ventricles on the left. I'm sorry if this is too simple if you're used to seeing it, but I found echoes really overwhelming when I started doing them. We're on the right side of the patient, so the right side of the heart is closest to the probe. So the right side of the heart is most superficial. Okay, so we've got right atria up here, tricuspid valve. You can just see here where my cursor is. Right ventricle. Our little right ventricle, he's only pumping blood to the lungs, so he's much smaller and thinner walled than the left ventricle, nice and appropriately. Then we've got left ventricle here, mitral valve coming across, left atria here. So that's our kind of bearings that we're going to focus on. Okay. If I show you this cine loop, I'm going to slow it down a little bit. I know we haven't spoken about pathology at all, but what we do when we first put the probe on is you first want to try and just get this view and just try to get your anatomy and try and visualize all four chambers. And in this view, we're kind of optimizing this mitral valve area. Just subjectively, does anyone want to make any comments about this cine loop? Because even just from this one view, there's quite a lot of information that we can gain about this patient. So I'll give an example. From this view, I can't see any evidence of a pericardial effusion. So we've already got that bit of information. Does anyone else want to make any subjective assessments of this view? I know you might not have seen a lot before.
I think there seemed to be some vegetations on the mitral valve, the
Yeah.
left AV, and the septum to me looks a little bit abnormal just below where the valves are.
Yeah. Yeah, absolutely. I agree. Anything else subjective we could say?
Say the atrium relative to the ventricle looks a bit big.
I agree. So when we get this kind of first view, in dogs, the left atria is always a bit bigger than the right atria. So the left atria takes up about two-thirds and the right atria about a third, but that's very, very rough. The left atria shouldn't be really, really rounded. They're, especially in cats, they're almost a little bit more square, and they shouldn't really bulge much bigger than the left ventricle. So, like Jeff said, this left atria subjectively could look a little bit big and rounded. It's very subjective. We haven't taken any measurements yet. The mitral valve leaflets are really thickened. So if I go back to this cine loop, can you see that beautiful thin line of the mitral valve? They're never completely straight, but look at this beautiful thin line of this septal leaflet. I'm going to refer to this leaflet here as the septal leaflet that goes up and hugs the septum up here. If we look at it compared to this big, disgusting, vegetated, chunky leaflet, he's really like a little club now, this septal leaflet. We've got an incredibly rounded and abnormal septal leaflet. So just subjectively, we can call that mitral valve thickened. The other thing that this mitral valve is doing, which is very common in it with degenerative mitral valve disease, is it's actually prolapsing into the atria. So as our mitral valve closes, our valve annulus across here should be beautiful and almost straight or slightly projecting out. As these mitral valves close, the leaflets, can you see how my mitral valve actually comes around and then actually prolapses into the atria before coming back out? It's a really subtle little movement. But we would make the comment just subjectively looking at this mitral valve, not only is it thickened and irregular, but it's actually prolapsing into the atria when you watch it slowly. And if you're ever doing this with and a patient is tachycardic, this is why we love giving everything butorphanol, even if they're quite calm, because sometimes they're just so tachycardic. Or just take your cine loops and then watch them back later. You can just get your views and then do everything later. So subjectively, we've got a slightly rounded left atrium and a thickened and irregular mitral valve that's prolapsing into the left atria. I hope you can all see that little prolapse that's happening. Is there anything else that we can comment on? What do you think about the right side of the heart? It's not a trick question if that helps.
I find it hard to assess it actually. It just doesn't look right at all.
It's really hard to assess the right side of the heart well from a right-sided view because it's so close to the probe. You often lose a bit of detail. So we've got like a little bit of lung, a little bit of artifact. But subjectively, it's probably quite normal. Our right ventricle isn't massive, our right atria isn't massive. They're both smaller than the left side of the heart. And would anyone want to make a comment on the contractility?
Point, it's not as good as it should be.
Yeah, so subjectively, we could say. So this view, we can get a lot of information even before we've taken any measurements, just subjectively on this view. And like I say, these principles can absolutely be applied to a POCUS exam. Is there pericardial effusion? Is there pleural effusion? Getting a subjective view of contractility and having a look at those mitral valves. Obviously, we know that degenerative mitral valve is by far the most common thing we see, which is why I've started with it. So this is a very, very common appearance of valves. And I can't emphasize enough that when I started, I found it very overwhelming to see subjectively until you do lots and lots and lots. It really is a numbers game. And then when you've seen lots of them, you can put the probe on and think, oh, okay, that's in heart failure or whatever you're looking for. Okay. How about, oh, how do I move you? Where's that cine loop gone that I want? How about this cine loop?
The valves look much better here than they did just before, but
Yeah,
that heart doesn't look like it's contracting really well.
yeah, absolutely. Yeah, excellent, Julian. So this is a dog with mild DCM with a reduced fractional shortening. So this would
There's
be a
some
very
echo dense material in the left atrium.
Yeah, do you know what's really annoying? You're so right, Jeff. That's actually completely an artifact, even though it absolutely looks like smoke, doesn't it?
Is the left atria a little bit smaller subjectively than what it should be?
Yeah, I would agree. So subjectively, it almost looks even with the right, doesn't it? Yeah. So we've got a lot of information just from this view. No pericardial effusion, no pleural effusion that we could see. Subjectively, reduced contractility, subjectively, reduced left atrial size. Quite a nice normal looking mitral valve, like Julian said. Good. Okay. How about this cine loop? This is a cat we're jumping to now. But exactly the same view, use the same principles.
That myocardium is very thick, is
Yeah,
it?
so we've got yeah, it is. It does. It has mild HCM, and we could always measure that to confirm, but it's great to make some subjective assessments. What do we think about chamber size? In cats, their left atria and left and right atria are often about the same size.
Looks okay.
Yep. What does anyone think about this that's going on down here? Ooh. All of this.
Do you mean like the hyper-echoic background at the bottom?
Yeah.
Is it something going on with like a pericardium that's
Oh,
abnormal?
that's a really good guess, actually. So we've got the pericardium is here that I'm tracing with my cursor. The pericardium is really reflects ultrasound waves, so we get that beautiful bright white pericardium. And then this is in the pleural space or lung tissue. So these are actually B lines in the lung tissue itself coming out. So we're actually just beyond the pericardium. Why this sort of home view, we call it the home view, this right view is so nice, is very, very subjectively, we can say, okay, maybe this myocardium is a little bit thick, but it's a beautiful way to just subjectively look at left atrial and right atrial size. If this was a cat in congestive heart failure, your left atrium is often, if it's in left-sided failure, is often really profoundly enlarged. And like we've spoken about before, we use the cutoff of 20 millimeters. We don't normalize cats to their body weight. We'll talk about that in dogs, but because cats are quite standard, we just simply measure the left atrium across in a very bog standard short axis view. So we literally freeze this cine loop. We've got left atrium and right atrium straight across, and we literally just take a left atrium straight across. Once cat's left atrium is over 20 millimeters, they're at really high risk of congestive failure or thromboembolic risk. So if this cat presented really tachypneic and dyspneic, and its left atrium is less than 13 millimeters, 12.7 we've got here. This cat is incredibly, incredibly unlikely to be in congestive failure. But the reason we were echoing it was because it was really tachypnic and we can see all these B lines. This is actually a cat that had toxo in and on thoracic radiographs. Its pulmonary infiltrates were really, really marked. But even in this one view, as soon as we put our probe on, we can say, okay, we can put congestive heart failure way down the list because we can measure our left atria and just subjectively look at those atrial size. But we know that there's thoracic pathology, or I should say that could be cardiac, of course, in origin, but we know that there's pulmonary pathology, I should say, from all these B lines that are present. But just subjectively, we know that our atria are looking pretty good. So we're going to stick with the same view. Well, that's a terrible view. We're going to stick with the same view just to get our brains used to looking at it. This is also a cat. And it's the same view. So feel free just to take time to orientate yourself. So we've still got our atria. We've still got our ventricle. This is plural, sorry. Would anybody like to make any comments about this cat's view?
That is a very large left atrium.
Yes, amazing.
And
There's a
it's got
large mass in the left atrium.
You can see a mass coming in.
does it have a little bit of pericardial effusion?
Yes, absolutely. So beautiful, bright white, really hyperechoic pericardium, pericardial effusion, ventricle. It's really easy to mistake a ventricle for a pericardial effusion when you're panicked. So we really want to look for that ventricle, myocardium, effusate, pericardium view. Beautiful.
Helen, the first cat had a slower heart rate, and that usually is an indicative of respiratory rather than cardiac problem,
Yeah,
whereas this one's a bit faster.
That's an excellent point. And I've actually slowed this down a lot. So this would be this cat's heart rate in real time. So it's pretty tachycardic. Yeah. Yeah, that's a great point, Jeff, actually using heart rate. So this is I've slowed it back down now. So subjectively, that's something we should add to the list actually. We can say we can get heart rate in this subjective view as well. Beautiful. So in this view, we've got a massive left atrium. We've got a mass. We've got tachycardia. We'll add that in. We've got a pericardial effusion. And what about beyond the pericardium? Down here where my cursor is.
A few more B lines again.
And we've got B lines. Great. Is this cat that's presenting dyspneic and tachypnic likely to be in congestive heart failure if you're trying to figure out why your cat's dyspneic?
Yeah.
Yeah, totally. So you can see how different their left atria look typically once they're in congestive failure. And this left atrium across is 25.5 millimeters. So it's double the size of the other cat's left atrium. And I know I'm showing you quite an extreme example, but cats are quite extreme. Like by the time they go into congestive failure, they're often quite severe because they're so difficult to pick up those early signs. Okay, beautiful. This is also a cat. I know this isn't the clearest video, but that's the reality of echoing. Sometimes your videos look awful.
It's really hard to make that out.
So if I ever can't really make out, I try and just go back to first principles. I'm just going to freeze this cine loop. They're often a lot more obvious when you're looking at it live, but if I can't orientate myself, I'm like, okay, right side of the heart, closest to the probe. This is my right atria across here. You can't
Atrium.
always make out the atrium. Thank you. You can't always make out the detail, but okay, right atrium. That means from here to here is my left atrium and my pericardium. Do they look about equal and not too rounded? Yeah, perfect. So subjectively, I'm going to say, okay, I think these atrium look okay. Then the right side of the heart, the poor right side of the heart that everyone just forgets about, he's all the way up here. This is our little right ventricle and our right ventricular walls. But it's quite normal in a cat to not really see the right ventricle because it's so much thinner. And when we're pressing on the right side of the chest, we're just going to squish that into nothing. So this is quite normal that we don't see that much right ventricle in a cat. And then what do you think's going on here?
It's almost like, is there like a, no, I feel like I'm interpreting, but it's like is it an outflow obstruction or something where it just seems like it doesn't, how to describe it, fully collapse down when ventricle contracts. Like it seems like it comes back, maybe.
Um,
As in, like, there's still a large black space there in the middle.
you mean here?
Yeah.
That's my terrible echoing. That's because I'm going into a bit of a five-chamber view and getting the left ventricular outflow tract in,
Oh, okay.
which is coming up here to the aorta. But you're
The
quite right.
ventricular walls really thickened.
Yeah, perfect. So we've got massive thickening of this ventricular wall. Have we got eccentric or concentric hypertrophy?
Concentric.
Yeah. So massive concentric hypertrophy. And you can see when cats' hearts get marked concentric hypertrophies, this is a cat with quite significant HCM. The ventricle looks like a bit of a mess because we've got a lot of chordae tendineae coming in. We don't get this beautiful, lovely elongated ventricle that we watch collapsing anymore. They often look a little bit rounded and really, really dead. So subjectively, we could say this is a really thickened ventricle. And we only know that because we've looked at some other cine loops. So I promise the more you look at, the more obvious it gets. If this cat came in respiratory distress, is this likely to be in congestive heart failure or not? You don't have to be definitive, but yeah, Julian's shaking his head for anyone that's just listening. I agree. So this is a cat with preclinical HCM. It's got a raging heart murmur. It's got raging HCM. Nothing to do with its respiratory distress whatsoever. Okay. What about this one? We're staying on cats. This is the last cat, and then I'll move back to dogs because I know everyone loves dogs.
Has it got a large right atrium or?
Yes, amazing. Can everyone see that? And what's happening to the interatrial septum?
It's being pushed into the left atria.
So this is a cat with profound right-sided heart failure, but we could apply these same things to a dog. We've got profound right atriomegaly, completely prolapsing septum. We can't really see the right ventricle because we've got that lung shadow that's coming in. What about the left side of the heart? I think it looks quite normal. Like we could see how with that other one that was really marked concentric hypertrophy, it almost kind of rounds out and just looks really messy to get a clear image of. I know we've got a bit of artifact, but this ventricle sort of stays nice and elongated. We can see our bright white myocardium quite nicely. It's subjectively probably quite normal. Okay, brilliant. So that's always the first view that we get with the echo. And we could take some measurements in this view. We can measure our right and left atrium just in long axis. In dogs, just taking that left atrial measurement isn't completely helpful and diagnostic. You can see this dog's left atrium just straight across is 36 millimeters, but we don't really have reference ranges. That's why we normalize it in dogs to their aortic root with the LAAO ratio, because their body weight size is so variable. Like I mentioned, because there's less variation in cats, we just say less than 20 millimeters, low risk of congestive failure, low risk of thromboembolic event, even if they do have preclinical cardiomyopathy. So from this view, we've got a nice bit of information. We are then going to rotate the probe. So from this view, we are in long axis with the heart. To get our next view, we're literally just going to rotate. And by rotate, I mean we're going to keep the tail of the probe down and we're just going to rotate about 90 degrees anti-clockwise. And we're going to go to our mushroom view. And this view I quite like because it's got a really good landmark. It's quite, when you're playing with the probe, it's quite an easy view to try and find because you've just got such a nice landmark. And what we're looking for is we don't want any mitral valve in this view. We just want to be just below the mitral valve, cutting through the left ventricle in cross section now. So we're in short axis through the ventricle. We want to try and make these papillary muscles either side really nice and symmetrical, like this. So it's never absolutely perfect, particularly in cats. And in this view, again, we can subjectively say quite a lot. We can look at pleural effusion, pericardial effusion. We can look at the right side of the heart. We can look that we've got a nice mushroom. And we can subjectively look at contractility. But if you have the option of an M mode on your ultrasound machine, which is when we place a line, we place a cursor straight through the heart, this is a beautiful view to get two really, really important measurements for heart disease. The first is our fractional shortening, so for DCM. So what we do is take our M mode cursor, which on your machine typically is just an M, and you'll come up with a line like this. And this line will be heading straight down, but you can usually use your rollerball to move it, to align it perfectly straight through the ventricle. So this M mode line has now taken a slice through, and it's M mode because it's motion. So we're looking at the motion in one slice through this ventricle. So we then get this M mode trace, which translates to, you can see the cursor up here is going through the right side of the heart. So here we've got a bit of artifact and kind of some subcut. Then we've got the right side of the heart, which never really looks like much when there's no right-sided pathology. That's normal. This first band from my cursor to here is our intraventricular septum. This big black, so remembering that blood shows up black on ultrasound, this big black is the left ventricular internal diameter. And then we're going to have the free wall down here. Because this is looking at motion, this is looking at a diastole here where my cursor is, where the ventricle has opened to fill, and then a systole as it contracts. And we're going diastole, systole, like that. One of the most important measurements, as well as subjectively looking at our left atrial size, is looking at whether our left ventricle is volume overloaded at the end of diastole. Because according to the EPIC criteria for whether your patient needs pimobendan or not, your left atriomegaly and your left ventricular volume overload are the two factors that we need the patient to fulfill both those criteria to be a candidate for pimobendan. The greater the left ventricular internal diameter is a surrogate, is a marker of how volume overloaded your patient is. We use end diastole because that's when the ventricle is the most relaxed and the most full of blood it's ever going to be, just before it contracts for systole. And the bigger that gets, the closer that patient is to going into congestive heart failure. And when they're actively in congestive heart failure and they're really volume overloaded, that measurement gets massive. So we put our M mode through. So the bit that we're looking at is this internal diameter. So this black from here, from my mouse to here at the end of diastole. Does that make sense as a concept? Yeah, brilliant. We then get a simple numerical value. So here we've got LVIDD, left ventricular internal diameter in diastole, and we've got a numerical value of 52.3 millimeters. We then normalize that for their body weight. There's plenty of calculators online. AI is also really good at it, that you can plug that in, plug your patient's body weight in, and it would then give you a left ventricular internal diameter normalized for body weight. And that's what you'll read, that if that value is greater than 1.7, that's one of our criteria for starting pimobendan. Patients in congestive failure, it's often greater than 2. It just gets higher and higher the more volume overloaded they are. It's quite I think it's quite an accessible measurement to practice in clinic. I actually think it's easier than doing an LAAO for sure, getting your nice mushroom view cursor through. And doing that in every patient is important, whether you're worried about them being in congestive failure or not, because that's also part of the staging for whether they need pimobendan. We're going to just ignore the other things up here for now. We don't really make any clinical decisions on them in dogs. The second thing that we want to look at is our fractional shortening. So here we've got percentage left ventricular fractional shortening. If you don't have a cardiac software on your machine, you can absolutely still do this. It just doesn't have this fancy table, but you can literally just do your cursor to measure that, and you can still calculate your fractional shortening. What do we mean by fractional shortening?
With the difference between diastole and systole and how much of that is reduced.
Perfect. So you can absolutely work it out yourself in the difference between how much we're contracting in diastole versus systole as a percentage change in how much that wall moves. And what's normal for a dog?
About
We usually say,
30%.
yeah, we usually say about 28 to 45%. So this is the dog that we looked at earlier that Julian, you identified looked like it had slightly reduced contractility. This has got a fractional shortening of 23%. So really consistent with a DCM phenotype. this patient.
How far out of the, like, if it's 1% out, can you just say that that's probably a like operator error? How
Yeah.
far out do you?
When I started doing this, I would do this several times. So I would do like 4 or 5 of these, and I still do sometimes, and then take an average. What other reasons can dogs have quite a low fractional shortening, but it's non-pathological?
Dehydration.
Um, yeah, although
Long.
sometimes with dehydrated dogs, they get a bit hyperdynamic because they're so volume underloaded.
Something like sedation or maybe like intense parasympathetic input?
Yeah, you're kind of on the right track. Like really young athletic dogs. So like
Hmm.
if I were to scan a border collie or something that does fly ball and I was getting fractional shortenings of like 25%, I would do a few and look at it in the context of the whole patient as to why you're echoing it and all your other markers. Because it's not uncommon that those and it probably is just that their resting yeah, their resting requirements are so low because they're so fit. Okay, perfect. So in this view, again, we're subjectively looking at our left ventricle. There are a few things that I think are interesting that can change this view quite significantly. Let me show you this view. So I feel like in this view, this mushroom is really obvious. Now it's even more obvious because this dog's got DCM, so it's not contracting as much and it's volume overloaded. But let's look at that compared to this view. So no one have any comments if you saw this view in practice.
That's contracting much better. It's expressing
Yeah.
nearly its full volume.
Yeah, it's contracting much better. So subjectively, we could say contractility looks better. We can do a proper fractional shortening on it. I
Is it
don't feel
all,
like, go on, Julia.
no, I was going to say something stupid, but I think I was going to
No,
say trying to find things there. Is it just not filling as well as the other one, or is it just a smaller heart?
love it.
Is
It might
the
not
is
go
the
for it, Kai.
intraventricular wall being squashed? Like it
Yes.
can't. Yes.
We've got flattening of the intraventricular septum, which turns this view from what we'd call a mushroom view into a bit of a Tesla sign. Do you guys see the difference in that? Instead of being this nice rounded mushroom, he's almost flattened to look more like the Tesla logo. What would flatten that interventricular septum, Carly?
Like pulmonary hypertension.
Yeah, absolutely. So what that could absolutely be one differential, and that is the differential in this dog. Well done. It had pulmonary hypertension. What are the other causes of pressure overload in the right side of the heart?
Congestive right-sided heart failure. But
Yeah, we could sit with right-sided heart failure, particularly a volume overload. What about a pressure overload? So if we're going to get
The
pressure
pulmonary
with
valve uh, constriction.
yeah, perfect. Yeah, pulmonic stenosis for sure. So if that right side of the heart, you definitely can get flattening with right-sided failure for sure and profound volume overload, but often it's with the pressure overload. So if you think that right side of the heart is pumping against the lungs and the pulmonic valve, so if we see this, we really want to interrogate both for pulmonary hypertension and pulmonic stenosis for sure. What type of
Heartburn.
dogs? Yeah,
do
yeah,
it too?
absolutely. Yeah, heartworm can definitely get it too. Yeah, that's a good one. What type of dogs do we think of that get pulmonic stenosis? So we see it in lots of breeds, but we really think like the brachy breeds, like bulldogs, anything that's brachy or a bit of a Staffy or a bulldog. Love getting pulmonic stenosis. So sometimes I know we shouldn't pattern recognize, but sometimes even with the signalment, if we're going to scan like a young Frenchie, I'd be thinking a lot more about pulmonic stenosis and a VSD, of course, or a PDA, than, for example, a Rhodesian Ridgeback or a large breed dog that we typically thinking about getting aortic valve disease. There's massive overlap in that, of course. Okay, good. That was very well picked out. So from this mushroom view, we've put our M mode cursor on. So I'm just going to show you another M mode. Oh, where's he gone? Oh, oh, he's gone. Okay, don't worry. From our beautiful mushroom view, so we've gone long axis, we've rotated 90 degrees into short axis. We're then going to tilt. So rather than rotate, where I keep my hand, my probe kind of level when I rotate like this, tilting is when I move the tail of the probe. So tilting, I would do this with my hand. So from the mushroom view, I would tilt the tail of the probe up towards me, and the probe would now be facing more towards the patient's head or spine. I feel like this just takes practice when you're doing it than me just explaining. And we're going to tilt from there into our LA AO view, which you can get a left atrium to aortic ratio in however when you want. Is anyone doing it in practice and does it kind of in sternal or yeah? So when you're wanting to do more of a thorough echo, it might look a little bit different than doing it in with your patient in sternal, for example. But you're going to tilt still from this right side. And in this view, we've got our aortic root here in the center that we want beautiful and rounded in the center. And then we've got our left atrium, I'm outlining now, sitting next to it. And we've got our right ventricular outflow tract that wraps around the outside here. We know that we want an LA to AO ratio of less than 1.6, so our left atrium to not be more than 1.6 times our aortic root. What do we think subjectively about this aortic to left atrial ratio?
It's a fair bit more than 1.6,
Yeah,
I think.
it's huge, isn't it? Yeah, absolutely. So this is a dog, um, actually borderline was basically tipping into congestive failure as we're scanning it. But so massive difference there.
Helen,
When
do you do this view in cats if you've already done your, is
yeah,
there any point,
do yeah, same view in all of them.
but you're
Yeah.
not doing your LA AO ratio?
Still get this view. You can absolutely still do an LA to AO ratio for sure. It's quite nice for just like monitoring and tracking a patient, but you can absolutely make clinical decisions just on your subjective assessment. We do still do this view because as part of a Filico, we're also going to be interrogating the aortic valve in the middle and the pulmonic valve, which comes in beautifully in this right outflow tract. So there are things that are still really helpful. In this view. So we do still get it in everyone. So in this view, we're going to do our LA to AO. We're also going to interrogate our pulmonary valve, our pulmonic valve, I should say. Let me just grab a. Sorry, I'm going to flick through all of them. That's going to be awful on your eyes. Okay. On all of our valves, we're going to put color flow on them all. And most commonly, we're looking at regurgitation. That is really, what did I just do with that one? Sorry, guys. Most commonly, we're looking at regurgitation when we've got color flow on. That's really, really turbulent. So I'm just going to slow this cine loop down. We've gone back to our first right parasternal long axis, and I've got color flow on the mitral valve. At what stage in the heart cycle does mitral regurgitation always have to happen?
Systole?
In systole, perfect. Heart is pumping, blood should be going out the aorta, it's going back through the mitral valve. Same for the tricuspid valve, should be going out the pulmonic artery, it's going back through the tricuspid valve. So in systole, we get this really turbulent color flow. I remember that blue, I'm really sorry if this is basic, but I feel like it's good to go over. Blue is away from the probe, red is towards the probe, mixed is doing whatever it likes. So we've got a really turbulent blood flow in our left atria for our mitral regurg. Okay, so mitral regurg and tricuspid regurg, we would just move this color flow window up and put it over the tricuspid valve, are quite nice to visualize. You can slow it down, you can watch for when you're in systole, bomb, goes through. The other valves that we look at and put color flow over are, of course, our aortic and our pulmonic valve. So from our LAAO view, we then interrogate the pulmonic valve because our right ventricular outflow tract wraps around the aortic root here, and it's a really nice view to look at our pulmonic valve. I know we can't visualize these pulmonic valve leaflets very well in this video, but if you imagine this is our right ventricular outflow tract, and this is in systole as blood is going away from the probe being up here. So it's nice and blue. It's going away from the probe through the pulmonic valve out into the pulmonic artery. And then in diastole, we've got this little jet of red blood, which is coming back through the pulmonic valve, and it's red, so it's coming towards the probe. So pulmonic and aortic regurgitation look very different. They look like these little, they're often quite small little jets. This is really typical of pulmonic regurgitation. Rather than that real turbulence, it's a jet of blood that's coming back. The valve sits across here. We just don't have the detail to see it. It's this little jet of blood coming back in the wrong direction into the right side of the heart. So from this, once we've done our LAAO, we'll also put color flow on here and interrogate the pulmonic valve. What are the common causes that we see pulmonic regurgitation?
Again, pulmonary hypertension.
Yeah, absolutely. We could see it with pulmonary hypertension for sure. And really, that's just that the pressure in your pulmonary vasculature is so high, it can be damaging to the valves. Why else might we see it? Probably the most common reason that we see it is just with dogs that have myxomatous valvular disease that we call mitral valve disease, but because that's where a lot of the pathology is clinically important, but actually all of their valves get leaky. So a huge percentage of dogs with mitral valve disease that we scan also have concurrent pulmonic and tricuspid and sometimes aortic regurg as well. It's usually clinically insignificant. So myxomatous valvular disease. And what about a dog with that you're worried had pulmonic stenosis? Do you think you'd see regurg?
I think probably not.
It's really variable. So sometimes no, and sometimes we can because the valve leaflets in a stenotic valve are often quite abnormal. So sometimes they don't seal properly, and you can get a bit of pulmonic regurgitation. How we know whether a regurgitant jet is significant or not is we'll then go to taking the velocities through here. We might touch on that in another time. Is anyone doing echoes in practice that's doing velocities or really interested in that? Are you doing that, Carly? Yeah. So the way that we would differentiate for starters, we need to know whether is the pulmonic regurg there just incidentally, or is this valve potentially stenotic or abnormal? We would measure the velocity both through the right ventricular outflow tract, so just before the valve, by using our pulse wave. Carly, have you got a machine that gives you PW? By putting our pulse wave gate just before the valve. We would then measure the flow through the valve, and often with pulmonic stenosis, that pressure gradient really increases. So you've got blood going out of your right ventricular outflow tract, then narrowed through the stenotic valve. So for the same amount of blood to get through that narrowing, the velocity has to increase. So you often get a relatively normal right ventricular outflow tract velocity and then a really increased velocity, kind of over 3 meters per second, or a pressure gradient greater of 30, actually at the valvular level. Pulmonic
So
stenosis.
sorry.
No,
Do
go
you
for
put
it.
the calipers at the valve or just like before it, or you do both of them?
Both of them. Yeah, both of them. So we interrogate right when we're happy that we're in the right ventricular outflow tract and not yet at the valve, and then we interrogate once we're at the valve. And that principle is exactly the same for aortic stenosis, obviously on a different view. Yeah, that we see that pressure gradient growing up. We often get some other changes, like some post-stenotic dilation, but that's not always the case. It's quite variable. So that pressure can be really, really helpful to make that diagnosis. And we're making that diagnosis in context with the whole patient as well, of course. You know, if you've got a
If
young dog.
there's is there like a standard sort of it can deviate by this amount, or is it if there's any change in the velocity between the valve and the
So usually we get pretty low velocities, like 5. Less than 30 we consider normal. 30 to 50 we consider consistent with mild pulmonic stenosis. But the reason that we just use the term mild is that there is grey zone and individual variation. Often in that 30 to 50, those patients aren't clinical and don't actually require any interventions. So if you were consistently getting pressures where you were worried, say like low 30s, it would be very reasonable to just rescan that patient or refer to a cardiologist if you wanted confirmation. But often they're so mild, they don't ever need any interventional therapy or definitive treatment for their pulmonic stenosis until the pressure's getting up at kind of over 50, 60, 70. Often they're clinical, and often we would then see that with remodeling of the heart as well.
yeah, okay. Thank
So there are little regurgitate jets by using our color flow. Carly, is there anything that you're working on at the moment, echoing, that you want us to touch on?
I really struggled with how to measure aortic outflow and doing like color Doppler and
Yeah.
getting the velocities.
Are you doing that from like a left-sided apical view, your aorta? Or are you doing it from a 5-chamber view?
I'm usually doing it from the left apical view. Sometimes I'll try to use the xiphoid, like up past the xiphoid, but I really struggled. I don't know if I'm just not figuring out where to put the calipers correctly, or yeah.
What
Got any tips?
I go from left apical. So now we're flipping. This image is, I don't think I have many good aortic, but this image is now with the patient in left lateral. So we've rolled over. And we call this a left apical view. So closest to the probe here, down at the ventricle. So I'm a little bit further caudal in the chest, and we're looking up through the heart. So I go from this view, and we're going to expect our aorta and our left ventricular outflow tract, Carly, to come in here where I'm circling. So what I typically do, I'm just going to slow it down a little bit, is are you doing mitral ENA waves with your PW? So we're going to put our gates right at the tip of the mitral ENA wave, and you should catch a little bit of a systolic signal in your ENA waves. That helps you just know which is E and which is A. Once I catch a little bit of systolic signal, I move my gate over, so it will be about where my cursor is for my left ventricular outflow tract. And I take a few until you get that beautiful dagger motion of your left ventricular outflow tract. And then I just make really gentle tilts. And by tilts, I mean I'm just moving the tail of the probe in either direction until my aortic valve is visualized coming in here. And often, because it's quite a nice bit of anatomy that's quite well defined, I do my LVOT right down here in this view, and then get the aorta just coming in, and then you can do your aortic view with your color flow. I have to say that it takes like a lot of patience. I mean, hundreds of patients, I honestly think, to be really comfortable doing those views. That's not
Yeah,
very
that's
helpful
my
advice.
problem. Patience.
Really does, yeah, it really does. And the more you do, the more the easier it does become, because you get really used to seeing normal. I'll see if I've got a that view that I mean. No, that's not very good. I mean, I will do, but annoyingly, we take so many videos. So this isn't super clear, but hopefully you can tell. So we're still at this left apical view. Left atria, left ventricle, right atria. My left ventricular outflow tract I would put here, because I can see a bit of my aorta coming in, and then my aorta comes in rounded here. Can you see that? If I slow that down, you can start to see the aortic valve leaflets coming in here. So you basically want to play until you optimize and see a beautiful rounded aorta, to then put your color flow over there. Does that make sense? Good. All right, guys, we might wrap up there. Thank you so much for coming along and learning about fun echoes.
Thank you.
Helen, that was nothing short of brilliant, that presentation. Congratulations.
Thank you, Jeff. I hope that was.
And your name would look good with an F after it. You should specialize. I mean, you're nearly there. It'll make a very big difference to your quality of life and enjoyment of your profession and your income as well, actually.
Yeah, I think we all feel like that. Studying does help you enjoy your job better, doesn't it? Because
yes, definitely. So please.
Thank you, Jeff. Thanks so much for joining, guys. We'll see you all in a couple of weeks.
Yeah.
Thank
Okay.
you.
Bye.
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 Bye.